of my thesis is randomized controlled trial for comparing conventional versus wide-angle non-contact viewing system for scleral buckling surgery. The principle of scleral buckling surgery is the indentation of sclera and choroid by providing an external tamponade that brings the retinal break closer to the retinal pigment epithelium and displaces the subretinal fluid away from the tear. Traditionally, the illumination and viewing has been done using an indirect ophthalmoscope with a plus 20 or plus 30 diopter condensing lens. Here we are comparing this with an endo-illumination via chandelier inserted through pars plana in combination with wide-angle viewing system. So the aim is to evaluate the results of treatment with the traditional scleral buckling compared to chandelier with wide-angle viewing system. The limitations of existing literature is that the studies have been retrospective with smaller size. There has been a lack of comparison group and they have not been done in Indian population. My study was a randomized single-blind controlled trial, and the patients with rheumatogenic retinal detachment with PVR less than grade C were included. Intervention group was group A with chandelier, illuminator and wide-angle viewing system, and comparison group was traditional scleral buckling with indirect ophthalmoscope. The primary outcome measured was anatomical reattachment of retina, and secondary outcomes were improvement in best corrected visual acuity and per and post-operative complications. We used a Consort 2010 flow diagram for transparent reporting of trials. 58 patients were included, out of which 12 were excluded, and then 46 were randomized into two groups of 23 each. The patients with deep set eyes and post-glaucoma or glaucoma drainage implant patients were excluded. The primary outcome was reattachment of retina, and it was evaluated on day 1, day 7, day 30 and day 90. And it did not differ between the two groups. Similarly, the best corrected visual acuity was also similar between the two groups. The secondary outcome was per-op and post-op complications. In per-op complications, in both the groups, most of the patients did not have any complications per-op, and subretinal bleed was seen in 2 patients. Additional complications that we saw with chandelier was there was a need to shift the chandelier in 2 patients because of poor visualization of break. Lens touch happened in 1 patient, leading to a rosette cataract. In post-op complications, in both the groups, they were similar. 1 patient each had media haze and subretinal residual fluid. Discussion, coming on to discussion, in 1980s, Bonnet M used an operating microscope with slit lamp illumination to view the fundus with a Goldman 3-mirror lens placed over the cornea. Later, in 2004, a surgical microscope with mounted slit lamp illumination was used, and later Ruchi et al. Used a office system, that is optic fiber-free intravitreal surgical system. Aris et al. Performed scleral buckling with a non-contact wide-angle viewing where the source of illumination was a torpedo light. In my thesis, I observed that the advantages of chandelier and wide-angle viewing system was a wide field of view with adjustable magnification, comparable rates of attachment. Additionally, it acted as a teaching tool with better ergonomics. But the disadvantages were that an intraocular entry had to be made for the chandelier, and there was poor view in hazy media, increased operating time in our thesis because of the lack of experience with chandelier, and the need to change position in 2 patients. Limitation of my study was that it is a small sample size with a relatively shorter follow-up period, and there is a learning curve owing to increased operating time and per-op complications. My conclusion is that the chandelier illumination with scleral buckling using a wide-angle non-contact viewing system, it yields comparable results in management of rheumatogenic retinal detachment and is non-inferior when compared to traditional scleral buckling using an indirect ophthalmoscope. These are my references. Thank you.
You have included PVR grade C?
Yes, sir.
Okay. So, was there any difference in grade 1, grade 2 and grade 3 in your finding in the use of chandelier illumination system?
So we only included grade A and grade B PVR, sir. And so no difference was seen with either chandelier or with indirect ophthalmoscope, sir.
Okay. So 4th port was made for chandelier? Or 3?
So 3 ports, there were 3 ports, and we, instead of the light source, we use a chandelier using a 25 gauge.
Why 3 ports?
Any complication related to that?
Yes, sir. So in 1 patient there was a lens touch and that led to a rosette cataract, and in 1 patient that there was vitreous incarceration at the port site. And in 2 patients we had to change the position of the chandelier because at the position that we had placed we were not able to visualize the breaks correctly.
Okay. So, as per your study, whether this is recommended to use or only same light source should be used?
Sir, because scleral
to chandelier usage or due to the inexperience of the surgeon?
No, sir, inexperience of the surgeons. A lens touch
So-
should not ideally.
that is a